This is an informal workshop, and pre-COVID, I think we might have been doing this in a smaller room, but I'm quite happy if people want to stop me during these slides and have a chat, or if they want to ask me questions at the end. Because what I generally find is I learn as much from the participants in these workshops as they may learn from me. So I've been a consultant now since 2008, and I started specializing in cancer medicine in 2000 under Professor Daly and James's, and it has been really fantastic to be able to help people much more with better drugs and better imaging and blood tests than when I started. But it's also been something which Professor Seamus O'Reilly in CUH first got me interested in, was this whole concept of survivorship and quality of life. And I think that sometimes when you start out training as a healthcare professional in cancer medicine, you're so focused on getting the diagnosis and the stage and the treatment right that you forget the patient. And it's nice to be seeing the patient coming back to the center where they should be. So, like I said, we have better drugs than we used to. And so we have some patients who wouldn't have been cured previously who are now cured. And we have patients who are living longer and hopefully with better quality of life with incurable cancer. But the side effects of these new drugs can be very different. Generally, quality of life is better, but the side effects are no less real. And the other thing is, not every patient benefits. So we are always looking for better ways of getting the right drug for the right patient. So there are these drugs called tyrosine kinase inhibitors, and these are normally tablets which patients will take once or twice a day. And they're more targeted than chemotherapy, but they still have side effects. There are side effects like rash, diarrhea, and they cross the blood-brain barrier, which is great for stopping cancer getting into the brain or treating it in the brain, but can also cause mood and epilepsy-type side effects. So we have to be aware that just because something isn't a conventional cell-killing chemotherapy drug doesn't mean that we don't need to treat it with respect and be open to our patients when they report side effects. So my daughter, who's 14, told me that my talk was incredibly boring, but she'd rescue it for me. And we're living in an era of immunotherapy. Now, we've known for hundreds of years that there are cancers which rarely go away on their own, and these would typically be melanoma and renal cell cancer. So there's something different about those cancers, that the immune system can wake up and get rid of them. And through a lot of incredible science and patients volunteering to go on these trials, we now have drugs that unmask the cancer to the immune system. So we're seeing more cure in certain cancers, and we're also seeing patients living longer, hopefully with better quality of life, with incurable malignancies. Again, I can sit with a patient and their family. I can tell them how patients like them did on average on certain studies. I can tell them what may or may not be in their favor from their past medical history and how fit or unfit they are. But I can't tell someone 100% whether or not immunotherapy is going to help them, because we don't have good enough biomarkers, which generally is anything that helps a doctor choose the right treatment for a patient. So I visualize the immune system or the T cells as attack dogs. And here you can see angry attack dogs going after cancer cells helped by antibodies. Now, those of you who like animals may have spotted the wolf hiding among the sheep. And this, I think, is how the cancer cell hides among the good cells of the body. And when we give patients these drips, these antibodies called immune checkpoint inhibitors, and we unleash the hounds, we're hoping that our sheepdogs will go after the wolf. But sometimes it gets it wrong and it savages the sheep instead. So the immune system is incredibly powerful. And there are patients who suffer from autoimmune disease without ever having had cancer and without ever getting any of these drugs. But you can see that when the immune system is unleashed by our drugs in an attempt to attack the cancer, it can attack any part of the human body. And so I normally tell patients about rash, shortness of breath, dry cough, diarrhea, but there's other things which are thankfully rarer. So I have had some patients whose melanoma has gone away, but they're now type 1 diabetics because their immune system has destroyed the cells in the pancreas which secrete insulin. So, like I said, any part of the body can be targeted by the immune system. It's not the intention of our treatment, but it's a side effect of it. And so what do we do then? Well, we've got steroids to calm the immune system, and most of the time we give a patient a course of steroids, wean them off the steroids, and the immune system settles down and leaves that organ alone. But if the immune system has destroyed the thyroid gland or part of the pituitary or the pancreas, we have to give that patient hormone replacement for life. There are maybe 10% of patients who suffer autoimmune side effects where steroids aren't enough. And that's when I have to get help from my colleagues in other disciplines. And if it's the lungs, I talk to a respiratory doctor, etc. And so one of the more serious side effects can be if steroids aren't enough to stop the immune system attacking the gut. And that's where my GI colleagues who treat patients with ulcerative colitis and Crohn's with drugs like infliximab and vedolizumab can come in and help me calm down the immune system. And unfortunately, steroids have real side effects: weight gain, immunosuppression, cataracts, arthritis. So it's one of these cascade of medical interventions that we start out using immunotherapy to treat the cancer, and then we have steroids and we end up having to treat or help the patient cope with the side effects of steroids. So, fatigue. There are workshops here on fatigue, and that's brilliant. So this was a really interesting study done in Australia where one of the Australian cancer societies looked for patients with melanoma. Australia's got a massive amount of melanoma because you've got people like me with red hair and blue eyes, at least I used to have red hair, and they have a lot of sunshine. And they found that 62% of melanoma patients who were on immunotherapy, who responded to their poll, had fatigue. So when a patient complains of fatigue, there's the simple stuff for your doctor to do. We check that the hemoglobin's okay, you have enough red cells. We check that your thyroid's okay. We can look for B12 and folate. And then there can be a role for antidepressants, for counselling, and you've heard a lot about the support the Irish Cancer Society gives today. Diet and exercise help mitigate fatigue. And what I found really interesting was some of the work that people who exercise find over time they can do more. They're more functional, but they still may feel as fatigued. So it's not anybody's fault if they feel fatigued, because some of these therapies, in ways that are poorly understood, cause a fluey feeling, cause increased levels of interferon. And so you know when you get COVID or when you get the flu, you do not want to get out of bed. Well, these drugs can trigger this in some patients. Now, this is some work I'm doing, and actually This work is sponsored both by Roche and by a patient donation to the Trinity Foundation. And I'm working with scientists in UCC and the pathology department in Trinity, St. James's, to look at better biomarkers. But this is a quality of life graph. And each box is a number of patients. And it's a small number of patients. But in general, this is one of my medical students presented this in Barcelona. Quality of life is better on this graph to the right, and patients who are only getting immunotherapy as opposed to getting immunotherapy and chemo had a better quality of life score when they filled in this quality of life score designed for patients receiving immunotherapy. So it is scary to hear about all the side effects, but both in terms of disease control and in terms of quality of life, it's much nicer to put a patient on immunotherapy than to put them on chemotherapy. So exercise is a treatment. It improves mood. It maintains muscle, which may have an anti-cancer effect. It probably boosts the immune system. And the fitter we are, the better we cope with adversity. But fatigue can affect motivation. And then the other thing is, and I learned this from the Australian paper I mentioned earlier, that there are lots of people who are very busy, and their housework, their gardening, minding their own children, minding their grandchildren, that's also exercise. And then they don't have time, or they're too tired to go to the gym or go for a walk in the park. But that's okay. Now, autoimmune side effects, at least they're proof that the immune system has been woken from its slumber, where it's ignoring the cancer. And so there is a slightly better rate of disease control in patients who have immune side effects. Hopefully we wean off the steroids, and then we'll decide whether we can just keep an eye on things, and if the cancer starts to grow, challenge the cancer again with the same or different immunotherapies. Or we can sometimes say, well, look, this is a really bad cancer, we've got a lid in it, we're going to re-challenge before it gets a chance to grow. But it's very much a trial and error. We have protocols, but there's a certain amount of clinical judgment and negotiation, discussion with the patient. But I do have a growing cohort of patients who have survived severe autoimmune hepatitis and other side effects of getting not one, but 2 immune checkpoint inhibitors at the same time. And these people are, as far as we know, cancer-free, years out from having a month or 2 of treatment. So there are some non-intuitive things about immunotherapy. I'm in favor of probiotics, but not when you're on immunotherapy. There are multiple data sets saying that probiotics may make immunotherapy less effective. There are drugs which stop you secreting acid, and antibiotics. Look, if you need them, but they may make immunotherapy less effective. And then I always ask my patients, if they ring in to our helpline with problems, that they say, hi, I'm on immunotherapy. Because how the doctor or nurse who takes your call thinks about you and whatever problem you have is different. Because we have to worry about, is this cancer? Is it somebody with a suppressed immune system or a chemo side effect? Or is it that the immune system is doing bad? And so if you gently remind your team that you're on immunotherapy, you'll get a better service. And a lot of the time, we can't tell over the phone or even by doing a history and exam what the truth is. And it's only through blood tests and scans and talking to our colleagues that we come to our diagnosis, our best guess of what the problem is, and try and fix it. So I met this patient in clinic 2 weeks ago, and I think it's a good story of the upsides and downsides of immunotherapy. So this is a man who one of my colleagues, Dr. Richard Bambury, who's doing a lot of the work in survivorship in men's genitourinary cancer in CUH, sent to me after getting excellent care with him because I was able to access atezolizumab free of charge from Roche. And he got 4 cycles of this immunotherapy, and he'd really run out of chemotherapy at this stage. So at baseline, the stuff in the middle of his chest is all normal, but the ringed circles are where the cancer was like golf balls in his lung. And we scanned him after the 4 cycles, and it looked worse, and he was more short of breath. So there's this thing with immunotherapy you do not see with other conventional drugs called pseudo-progression, where the immune system is attacking the tumor and the scan looks worse. But generally, if someone's got pseudo-progression, they feel better. But he not only did his scans look worse, he was more short of breath. So we decided to keep an eye on things, and when I scanned him 6 months later, he had very little cancer left at that stage. So we sometimes see these delayed regressions post-immunotherapy. So after his 3 months of immunotherapy with the atezo, his disease came back, he got a little bit of oral chemo, came off it for fatigue, and then I wasn't able to access atezo, but I was able to get nivolumab from BMS. And he had another fantastic response to nivolumab. But interestingly, with nivolumab, he got crippling fatigue and insisted on coming off the nivolumab, which from my point of view was working perfectly. And now his disease is growing back. We're going to re-challenge with nivolumab, presuming we can get access to it. Because these drugs are very expensive, and while there's better access through the National Cancer Control Program, it's not as good as we'd like it to be for all the cancers that could potentially be helped. So what were my learning points from his experience? Well, why is he an exceptional responder? Why does his cancer respond so well to 2 different immunotherapies? Why does the nivolumab cause fatigue and not the atezo? And it may be that they bind to slightly different sites in the same pathway. And the other thing is that it really was an eye-opener to me that his quality of life was so poor that despite the fact his tumor was controlled, he chose to come off treatment. So we do need better ways of diagnosing and helping fatigue. So where are we going? Well, as you can tell, I'm a little bit obsessed with biomarkers because I want to be able to pick the right drug for the right patient. We're starting to use immunotherapy in high-risk populations, people with HIV, people with a history of autoimmune disease, where we've always been reluctant that we will flare the autoimmune disease and cause the patient more harm than good. Now, this is a little bit disturbing, but there are Israeli and US trials where patients whose melanoma was not responding to immunotherapy got a poo transplant from patients whose melanoma was responding, and in a substantial number of them, their immune system woke up. So we live in harmony, hopefully, with billions of bacteria in our gut, and this is called the microbiome. And I think we're only starting to understand how important the microbiome is in health and disease. There are new types of immunotherapy which are becoming available, targeting different pathways that may be more effective and less toxic. And then in some of my research, I've duplicated other research which shows that high levels of neutrophils, a type of white cell that we normally like because it kills bacteria, in the patient's blood at baseline may protect the cancer cell from immune attack. And I said, I wonder, is anybody doing anything about this? And there are these new types of drugs called neutrophil inhibitors going into clinical trials. Now, I have no idea if they'll work or not, but it's really interesting to see that medical oncologists, scientists, and immunologists are all working together, and we're learning more about how the immune system actually works, because we now have drugs that throw a spanner in it to try and wake it up and kill the cancer. So this is some nice pictures Dr. Corrine Ronan, who's a specialist registrar in oncology, did, and it's the work which we're doing looking at changes in blood, in tumour, and what bugs live and don't live in the patient's stool sample to see who benefits most and who's at risk of side effects. So hopefully, before I retire, we're going to be sequencing the patient and the tumour genome. We'll be looking at the fecal microbiome. We'll be looking for tiny fragments of tumour DNA in the patient's blood and what immune cells are switched on and off in the blood. Perhaps we'll be doing not just a PET scan, but an immune PET scan to see where the immune system is active. And the goal of all of that is to help patients so they can live longer with fewer side effects. So to wrap up, we're in a very exciting phase, but nobody ever said, I want to go on this cancer journey. These targeted drugs have real side effects, and it's by listening to patients, identifying what the side effect is, and then we have to grade it. So I have an app on my phone for how to grade every toxicity, and then you plug it into the protocol and you get the guidance, but you have to then tailor the guidance to that individual patient. There's always going to be an element of trial and error. So if we have to, we use steroids. If the steroids don't work, and we're going to something which, as an oncologist, you know about, but you're not going to be using it every day, you need a colleague like a gastroenterologist to hold your hand and help the patient. So that's it. The Panda and I thank you for listening, and I think Eddie will do a good job helping me learn more from you. Thank you.
Dr. Brian Bird, thank you, Dr. Brian Bird. So super. What an area of work you're in. Really interesting and so growth area, the whole immunotherapy area. It's like, where would you say is that? Like total infancy or?
I think we're toddlers.
Yeah, okay.
So
Toddlers.
I remember when I was a fellow at National Cancer Institute,
Yeah.
one of these drugs was on trial. And I'd always been interested in immunology, and one of my mentors had said, don't go into immunotherapy. It's always been promising, but never doing anything. And I was about to leave and come back to Ireland, and there were a lot of toxicities on this trial, and we were only just learning how to manage them. And I just thought, oh, it's another interesting drug that won't work in the real world. And I was completely wrong. So that was maybe when we were at our crawling stage. I think now we're at our toddler stage. Do you know anyone who's got a toddler and they can run fast and they've no fear of traffic? That's maybe where we're at. So there's great potential ahead.
Okay, so it's an exciting phase. It's a
Yeah.
growth phase.
Yeah.
And hopefully we're not talking about the space of human development and that you get to other phases fast.
Yeah.
That's what we want. Any questions in the room or outside the room, you can throw them in on our hop in. Anyone, any questions? I put my hand up because of the lights there. Yes, we have some down there. Right, thank you.
Hi, thank you very much. I'll keep it short. It's not so much a question as a comment. Thank you very much for all your hard work and all the people that are involved in research in this particular area and the advances that are being made. I was at this conference in a different location a number of years ago, and I attended the talk in relation to, I find it difficult to pronounce the word, immunotherapy. I'm a non-medical person, but it's very interesting as a new area. But I came away from it thinking that it was in very limited areas that it was suitable for. And from memory, I think it was possibly in relation to lung was the person who spoke, I came away thinking, it was more or less ideal in that particular area. So it's more encouraging to hear now, am I right in saying that it has advanced in more years as to its suitability, and in particular in conjunction with other other treatments as well.
You're entirely correct. So immunotherapy started out in the low-hanging fruit of melanoma and kidney cancer. And then one of the big next places it went is lung cancer, either on its own or with chemotherapy. So at the moment on my small study, 12 of the 15 patients on it have various forms of lung cancer. And lung cancer has gone from being something which, as a clinician, was quite painful to treat because most of the people you met would not be there in a year's time. But now, not everyone, but a substantial minority, there are people and their families you get to know over years, and there are many more targeted therapies. And these days, when someone has lung cancer, my pathologists are like, yes, relax, Brian, I've put tissue aside for molecular studies and PD-L1 staining, PD-L1 being one of the immunotherapy targets. And unless it's an emergency, it's wrong to start somebody on treatment until you have the PD-L1 status and the molecular report. And it's great that we've got more and more Irish hospitals, including CUH, who are doing next-generation sequencing of cancer so that your clinician can choose the right drug for your lung cancer, so to speak. So immunotherapy does not work for all cancers because we rely on the cancer being sufficiently different that the immune system can recognize it. So there's a common hereditary cancer syndrome called Lynch syndrome, and Lynch syndrome tumors are very immunogenic. So I have patients with metastatic colon cancer and Lynch syndrome, and if I can get their immunotherapy funded, they do very well. But normal non-Lynch colon cancer, which is the 90-95% of metastatic disease, generally ignores immunotherapy. So there's a lot of work going on into how do we break tolerance, how do we wake up the immune system to attack the cancers which don't respond to current immune therapies.
And also, just last question very briefly, in relation to breast cancer and immunotherapy, is there a lot of research going on and is there positive information coming down the line?
So I've moved out of the breast cancer area for almost a decade now, but my colleague, Dr. Con Murphy and Dr. Deirdre O'Mahony, who treat breast cancer, would have a growing number of patients with triple-negative breast cancer who are getting immunotherapy. So again, with every cancer, it used just to be you have breast cancer. Then it was you have hormone receptor positive or negative, then what's the HER2 status? But we're getting better ways of slicing the pie chart to pick out, this is the type of breast cancer that will respond to immunotherapy. So most patients with breast cancer, to the best of my knowledge, and I'll be first to admit I'm no longer fully versed in the field, do not benefit from immunotherapy. But there certainly are a minority of breast cancer patients who do, and I think it's a fairly safe bet to say that in 10 years' time, maybe 30 to 40% of breast cancer patients could benefit from immunotherapy, but who they are and what those drugs will be, I don't know.
Okay, thank you, and well done on all your hard work.
Definitely, and Brian, one of the things is I want to commend you too, because you work in a very complex field, but your capacity to communicate that to us in the room is very clear, and I commend you on that, because that can be very difficult at times, and I really appreciate that, so I can.
Well, you should have seen the talk before my wife and daughter savaged it and told me it had to be comprehensible and it had to be at least amusing so people didn't die of boredom.
Well, definitely no one's there to boredom, man. But and it's been very clear. It's been crisp and clear. I really like it. Any other questions there?
Hello, Doctor. I gather from what you just said that I might be in the minority group then that are benefiting from immunotherapy, which is trastuzumab and pertuzumab for stage 4 breast cancer, which has spread to my lung and my bones. I've been on this now for a year. Initially, it was given with chemotherapy, and you know, after when the chemotherapy finished, I was scanned, and as they say, the chemo had done its job. So I'm continuing on the immunotherapy, which, please God, will be for a long time. It's going well, as far as I know. I'm not suffering obvious side effects, even though you said in the slide that all.
Could I just come? So, the immunotherapy which I was talking about is quite different to the immunotherapy which you're getting. So you're getting something which is generally called passive immunotherapy. You're getting this infusion of antibodies that stick to your cancer and both stop signaling inside the cancer to slow it down and may make it a better target for the immune system to attack it. And those passive immunotherapy drugs are fantastic, and they're relatively non-toxic. And while they have side effects, passive immunotherapy doesn't cause autoimmune disease, whereas the drugs which I was talking about are antibodies that actually deliberately wake up the immune system, cut the brakes that are holding back the immune Lamborghini, whatever metaphor you want to use. So there's a big difference between the type of passive immune therapy that you're getting, which is generally very well tolerated on its own without chemo, although it can have side effects, and I'm happy to hear you're not having any, and the more active immune therapy which causes autoimmune disease. And the other thing I was going to say is that there are some really exciting new drugs which are based on trastuzumab, which are like trastuzumab with chemotherapy strapped to it that get delivered directly into the cancer cell, and drugs like TDM1 and trastuzumab deruxtecan. These are drugs which, in the type of breast cancer you have that overexpresses a target called HER2, and in some of my patients with gastric and colon cancer that overexpresses HER2, hold great promise, but it can be very hard for us to get our hands on those drugs at the moment.
So all in all, would you say that the outlook for the type of cancer that I have in general is good?
So I would, both because from what you've told me, you've had an excellent response and you're tolerating your dual antibody therapy very well, and because if and when you need another line of treatment, which hopefully is many years away, there are better drugs available right now, and even better drugs that should hopefully be coming to market in the near future. And there are some of these drugs which I remember being at the American Society of Clinical Oncology when the Herceptin data was shown and seeing unemotional doctors cry. And there are drugs now which are even better than that for patients with metastatic HER2 positive breast cancer. So I do think there's a lot of hope out there.
That's very reassuring. Yeah, Thank you, Doctor.
Thank you, Brian. Any final question? Anyone got a final question there? Do I see one more? Thank you very much. Very interesting questions. Thank you.
Drug for...
We'll just get you to start again.
Sorry. I'm on a research drug for melanoma lung cancer, which thankfully is working really well and the tumour's reduced. But having had scans, they now discover I've got a thickened bowel and I've got ulcerative colitis. And I just wondered, who do I see or what do I do about it? Because I've just been to the dietary talk and they're saying I should eat lots of fibre, but then that contradicts what I should be doing for ulcerative colitis.
So again, I think that I'm delighted your melanoma is responding to whatever trial drug you're on. And I suppose the question arises, did you always have ulcerative colitis that wasn't known about until it was picked up on a scan? Or was your ulcerative colitis triggered by your trial drug? And I think this is something that your trial team would be very happy to talk with you about, because it's a well-known, colitis is a well-known side effect of most of these immune therapy drugs. And some of the tyrosine kinase inhibitors that target a subset of melanoma with a particular mutation called BRAF, they can also cause a drug-induced colitis. So, you know, I'm sure that these days, any trial of an immunotherapy drug will have a protocol for how to manage colitis. Now, if your colitis is just a thickening on scan and not actually causing symptoms, it's not as worrying as if, for example, you're having 4 episodes of bloody diarrhea a day. So there can be a problem when the patient is well, the cancer is controlled, but there's a minor abnormality on a scan or a blood test that causes understandable concern. But the best thing to do is to talk to your trial nurses and talk to your trial doctors, because this should be managed by them, if needs be, in consultation with gastroenterology.
Thanks very much. So, Brian, thanks so much. Really appreciate it, folks. We're going to head to lunch, so we are. Lunch is out in the restaurant. Once again, I want to give Brian a clap, and I really appreciate you coming here today. Thank you so much. And what a great morning sessions we've had. Really appreciate you staying in the room for the 2 workshops, and we look forward to connecting with you after lunch. So good luck to you all at home, and we'll see you all after lunch. Take care now. Bye-bye.